is how crucial time is when we talk about stroke in a brain that's having a stroke, and what that means for our options in terms of treatment. So next slide. I'm going to start with a question, and feel free in the chat or just come off mute. If you had to guess how many neurons die every minute during a stroke, let me get some thoughts here. Anyone like one of these answers? C? Okay. Anyone else? Another C? So we've got some savvy test takers here. If you don't know the answer, it's always C. So go ahead, next slide. Oh, sorry, Neil, it's C. So yeah, 2 million neurons every minute die during a stroke, which is pretty impressive. And if you go to the next slide, you can, that essentially, if you lined those neurons up from end to end, 2 million neurons, you could stretch a length all the way from Highland Range Hospital up to the tech center. So that's quite a bit of brain tissue that we start to lose. And again, that's just in 1 minute. Next slide, please. And probably one more. And every hour, if you look at how much brain tissue we lose in an hour during an acute stroke, especially in a large acute stroke, you could stretch a distance, taking the highway all the way from Denver to Wichita, Kansas, which happens to be where I went to high school, so that's why I picked it. All right, next slide. And so there was this interesting paper that came out in 2006 where they tried to quantify that brain tissue loss and how it ages the brain during a stroke. And what they came up with is that an ischemic brain ages around 3.6 years every hour without treatment. I don't know if any of you guys have kids or grandkids that like this movie. It's hard to get through without crying, but so especially if you're into neuroscience, because the protagonist has dementia. So I thought it was a good example. So anyway, I say all this to drive home the point that when we're talking about acute stroke treatment, when we're talking about recognizing the signs of stroke, getting to the hospital quickly, this is really the reason that we harp on that so much, is because the brain really does take a toll. And even minutes can make a big difference in terms of how much tissue we're able to save versus how much tissue is potentially lost. Next slide, please. So some statistics about stroke in the United States. Starting at age 25, 1 in 4 people will experience a stroke. Put in another way, that means there's a stroke every 40 seconds in this country. Next slide, please. The difficult part is that studies have shown that only 1 out of 4 people know the sign of stroke. So fortunately for you all, when we're done here tonight, you will not be you'll be in the 1 of 4 at least. Next slide. So does anybody want to yell out, or even in the chat, give me some signs of stroke? What are you looking for, or what are you worried about?
People can't stick their tongue out.
Okay, so maybe trouble with tongue movement. What else?
Rapid eye
speech,
movement.
I see. Say that last one again, sorry.
Rapid eye movement.
So sometimes we'll see people, maybe not as much rapid eye movement, but we'll see people who have who have trouble moving their eyes in all directions. So they may only be able to look to the right, for instance. Or they may say that they can't see a certain part of their vision, like the whole left side is missing, or the top left is missing, or something like that. I see facial droop. I see one-sided weakness, non-responsive. These are all really good. Go ahead and go to the next slide. One of the things that we around UCHealth, we've sort of settled on at least trying to promote this idea of be fast. Which is a kind of a simple way, an acronym to remember some of the signs of stroke. You guys have really hit on all of these, but I don't know if I saw anything about balance, but the B stands for balance. So being unable to walk straight or falling, Again, these are things that happen acutely. So like they were fine 1 minute and the next minute they can't do this or this looks funny. The stroke happens really fast, all at once, usually develops over a few seconds. The E stands for eyes. So we talked a little bit about not being able to focus. Maybe that means that because their vision is missing a chunk, or because they can't move their eyes to one side, or because their eyes are not aligning anymore. An uneven smile, if one arm is weak, if their speech is slurred, meaning it's kind of hard to understand them, or speech can also refer to their language. So are they unable to understand you? Or when they speak, is it kind of gibberish or stuttering, like they can't get their words out? That would be a sign potentially of a stroke. And so the T stands for time to call 911. And that's another key point. We receive a lot of stroke patients by private vehicle at pretty much every hospital that treats stroke. A lot, maybe up to 50% or even more come by private vehicle. But we know that ambulances typically do a better job of getting patients to the hospital faster, partly because there's more support to get them into the vehicle. You're not trying to help them into a car when they can't walk very well and all that kind of stuff. So if you see signs like this in yourself or in someone else, we really think that calling 911 is your best bet to get rapidly to the hospital. Next slide, please. So far what we've established is that stroke is really common, 1 in 4 people after the age of 25. We've gone through some signs of stroke, and we've talked about how time matters, because as you remember, you're losing 2 million neurons every minute while a stroke is occurring before we can get to treatment. So what are our treatment options? Next slide. We're going to think about our treatment options a little bit in the framework of how long is the stroke been going on. So our options change as the stroke ages. And so we'll start with the most basic and the longest standing treatment of acute stroke, which is what we can use in that first 3 to 4.5 or less hour time frame, which is IV treatment, IV clot busting medication called Alteplase or TPA. Some of you have probably heard of this medication before. And then after we talk briefly about that, we're going to get into some of the newer techniques, which have really, and Dr. Folzenlogen will go into more detail on some of those, which have really not only improved our outcomes, but also stretched the time frame with which we have options to treat strokes, all the way out to even 24 hours in some cases. So let's start with the TPA first, though. Next slide, please. So you can sort of think of stroke care in terms of what happened before 1995 and what happened after 1995. So a critical trial came out in the mid-90s, the NINDS trial, which is an acronym for a very long title there that you can see, basically testing this medication and initially within 3 hours of onset of stroke symptoms. Again, so that timing is very important. 3 hours goes by really fast, if you're not careful about it. And what they looked at was a dose of 0.9 milligrams per kilogram of this TPA medication in those 3 hours. And they assessed outcomes in terms of disability following that. And what they found was a clear reduction in disability with that dose within 3 hours. And so this was really a landmark trial, which gave us an option to treat acute strokes in a timely fashion and in a way that we could prove improved our outcomes. And so this was a huge benefit, but it also forced stroke hospitals or hospitals that take care of stroke, such as our hospital, Highlands Ranch, to really design systems around these timeframes and to say, okay, how can we identify these patients quickly? How can we, expedite the process to get them treated? Because if they arrive 30 minutes into their stroke, even though we have up to 4.5 hours to treat them, we don't want to wait that long. We want to treat them in the first 15, 20 minutes if we can. So this was a big deal when it came out. Next slide. And I should mention that there were some subsequent studies that tried to extend that window from 3 hours beyond to 4.5, even 5, 6 hours. The studies that looked at extending the window to 4.5 hours also showed benefit, although it's a slightly smaller benefit. Pretty much every study that's looked at TPA from last known well outside of 4.5 hours has not shown additional benefit, and the risk of bleeding from the medication goes up. So 4.5 hours is really our cutoff for when we can use that medication. So next slide, please. So I like this slide. I stole this from a friend of mine, or from a colleague of mine, but we were trying to find ways to treat patients with stroke beyond the 4.5 hour mark. And we kind of went through the dark ages a little bit of those attempts. So if you go to the next slide, I don't want to go into detail with any of this, but there were a number, and you might have to forward it a little bit. I think it pops up in like waves, but there you go. There were a number of trials in the late 90s and early 2000s with sort of primitive devices that really struggled to show any benefit. And these were devices that were sort of designed to go up into the brain interventionally, which Dr. Folzenlogen is about to tell you about, and to retrieve clot when we can see it there. So we were a little dismayed at first, because it seemed like, okay, if you know there's a blockage in the artery and you know where it is, and you go up and you pull it out, shouldn't you see some benefit? And the early results were not promising. But now I'll let Dr. Folzenlogen take us out of the dark ages into some of the newer stuff that we're doing. I think you're on mute still.
Sorry, everybody. So as Dr. Pope was saying, those initial devices were not great. The corkscrew-looking device was really the first to go after these blood clots that we can now see on CT scans, and it just wasn't a great device. The idea, however, of removing the blood clot by a mechanical means grew, and people started developing new devices. And the one that really made things improve substantially was called a stent retriever. Now, we had been using stents inside the head for a number of years, mainly for assisting with coiling aneurysms and treating atherosclerosis like they do in the heart. Somebody who was at a device development used one of those stents, but didn't remove it from its deployment wire, and they were able to grab some of the coils so that they could repeat their study. Well, a light bulb went off in somebody's head and said, oh, well, this is perfect. We could use this for blood clots. And so that began the era of stent retrievers. And I'll show you a picture of what these look like in the next few slides. But there were a number of studies that came out in 2015 using these devices out to 6 hours with some other criteria that you had to meet that showed we were not only able to remove the blood clot a significant amount of time, but it substantially improved patient outcomes. The outcomes were so great. A number needed to treat means how many people do you have to treat to get a benefit? Well, that number seems kind of high, but in the era of, or in medicine in general, that is actually very low, meaning it's a very effective treatment. Next slide. So this is what a stent retriever looks like. We use these under X-ray. We take small catheters and access the big arteries in your legs called the femoral artery, or in your wrist called the radial artery. And under X-ray, we can navigate these stents up into your head where the blood clot is, deploy it across the blood clot, allow it to grab onto it for a couple of minutes, and then essentially snare it out. So that picture on the top left is what the dimensions are, basically. Well, there's no numbers on there, sorry. The picture on the right shows what it would look like endovascularly. And then the picture on the bottom left is actually what it looks like when we remove it from the body. And that would be a very successful retrieval. It's really not a lot of clot. These are very small blood vessels that really are important, essentially. And that actually is a very large clot right there that we had removed. Next slide. And these trials, again, just demonstrated superior care when compared to the standard care that had predated it, namely the TPA itself. And so if you met certain criteria and you were under 6 hours, we saw that one of those large vessels inside the brain was blocked. The treatment of choice now is to go out and try to remove it by using a stent retriever and suction devices. Next, please. And so the benefit, that's great. I didn't realize that was going to be a video. So again, the absolute benefit of endovascular therapy as compared with TPA alone with regard to outcomes at 90 days. And what we use is a scale called the modified Rankin score, which essentially is saying, are you independent? Are you able to do things around your house? Are you able to cook for yourself? Are you able to, next slide, please, sorry. Are you able to cook for yourself? Are you able to use the restroom on your own? So that's what that modified Rankin scale means. And this, again, translated into a number needed to treat as low as 3, which you would hope that all people would receive benefit, but that is quite good, and no more than 7. And there was no significant increase in the rate of hemorrhage with endovascular therapy. So anytime you're going up and manipulating the arteries in the brain, there is a small chance that you can break them and cause hemorrhage. It is very small, and it's no different than just giving that anticoagulation medicine or that clot busting medication, TPA. Next slide, please. And then we move into the Dawn era, and there were a couple of trials. The Dawn was the big one, and there was another one called Diffuse. These were studies that said, well, heck, this works out till 6 hours. Why doesn't it work any longer? And so this was the beginning of a more sophisticated way of analyzing our patients and who would benefit from going up and removing these blood clots after 6 hours and even out to 24 hours. Now, the thing you've got to remember, and this goes back to the timing issue, is that once the brain dies, we can't do anything about it. It doesn't regenerate. We can't bring it back to life. But if it is starving for oxygen and it has not yet died, those neurons have not yet died, then we can intervene, get them the oxygen that they so desire, and prevent large strokes. So this study looked out till 24 hours. Next slide, please. And they're named after cleaning products here. They have very long names that I don't even remember most of what they are, but they all have long acronyms. So next slide, please. And again, Dawn was evaluating that modified Rankin score. How independent are people after they have these procedures done? So this study was done in 2008, concluded in 2008, and published in the New England Journal of Medicine. And it analyzed different groups of people, depending on their age, greater than 80, less than 80, how their symptoms were when they presented, and exactly how large the area of the brain was that was affected and how much had already died. Next slide, please. And so this is a cerebral angiogram, okay? This is what I'm looking at when I'm doing the procedure. If you look at the picture on the right, that is an angiogram where there is a large vessel occlusion, or you can see that one large dark vessel abruptly stops. When compared to the left, you can see that we have opened up that vessel again, and that territory is now filling. And you can see that you can actually see one of our devices inside there. So the reason that we are able to stretch this procedure out now till 24 hours is that as we age, Sometimes our brain, the vessels in our brain, find alternate routes to get blood flow to places. And those alternate routes can take over for a period of time, not indefinitely. That's why we still try to remove these large vessel occlusions or these large blood clots, because even though we may have some new little pathways that have developed over our life, they're just not the big highways that we need to get oxygen to the brain. The brain tissue uses an extraordinary amount of oxygen and glucose because it's constantly working. I mean, you're thinking constantly. It requires a ton of energy and a ton of energy conversion. Next slide, please. And technology has just made this amazing, okay? And so one of the things we need to do now is have some more advanced imaging to tell what are those areas of tissue that are really starving and what areas have already died, because it's important. If that area has already died, unfortunately, nothing we do will improve that. But if we see that there are starving areas, we can go in and remove that blood clot and really help the patient out. And technology is amazing. If you go into the hospital with this and go under our CT scanner and have these studies done, it shows up on my iPhone sitting at home. So I have advance notice to get in the car and start driving to Highlands Ranch so that we can get the treatment done. Next slide, please. And this is just more of an example of that advanced imaging. It shows us areas that have already died and some areas that are going to potentially be at risk and are really starving for that oxygen. So areas we need to open up. Next slide, please. So we're going to start with a little clinical vignette. This is just sort of a case to illustrate exactly what we would do in these certain situations. So we have a patient that presents to the hospital. Time of last known well. That's important for us. That's where the clock starts. That's where that TPA clock to 4.5 hours starts. That's where the procedure to 24 hours starts. So really important that if you take a family member into the hospital with these symptoms, that you try to ascertain when was the last time that you saw them normal. In this case, it's uncertain. Nurse staff documented that deficits were seen at approximately 8:30 a.m. in the morning. EMS was called at 8:45, and by 8:50, they had diagnosed in the field a stroke based on the symptoms they were seeing. So they go ahead and they give us a call saying that they have a patient with a possible stroke on the way. That's called a pre-hospital stroke alert. That alerts all of us that you're coming. On arrival at 9:20, blood pressure looks good, 112/62. The stroke team confirms the exam that the EMS team had described, and this goes back to the symptoms that Dr. Pope talked about. Global aphasia, meaning difficulty talking, right-sided weakness. Now remember, the left side of the brain controls the right side of the body, and unable to blink. When we blink to threat means we move our hand towards your face, and most people will go ahead and blink. But if you're lacking vision in that area, you won't blink. And then some minor facial weakness, basically. And then a left gaze predominance, meaning they're looking to the left and don't want to look to the right. We have a scoring system that the nurses are awesome at scoring up, and this really tells us kind of how bad things are, and it has implications as to whether or not we pursue the endovascular treatment that I do. In this case, we mark it as an 18, which is actually pretty high. Next slide, please. And so the patient goes into a CT scanner, and unfortunately our arrows are off. I am so sorry. So disregard the red arrows. Can you see my cursor at all? Or who's got the cursor? Can you go to the CT and, well, anyway, we get a CT scan right off the bat. Why do we get a CT scan right off the bat? Well, we want to know if you're having a bleed. Okay, some people present with very similar symptoms, but instead of having blockage of the artery, they have bleeding of the arteries, and that can look very similar. And so when there's bleeding, obviously we don't want to give you clot busting medicine. We want that blood clot to form a blood clot and not continue bleeding. In this case, we didn't see any bleeding, but they got a CTA, which demonstrates a blockage. Now the arrow, looking at the picture on the right, the arrow is actually on the normal side. I apologize, it somehow shifted. The other side, you can see that there is no branch going out to the right. And so that is a large vessel occlusion. It's a branch of the middle cerebral artery, one of the big arteries that controls movement, those eye fields, speech. So very consistent with the patient's exam. Next slide, please. And so then we may get some advanced imaging. This is an MRI. Basically, what an MRI will show us is, has there already been a large stroke? One that we can't do anything about. In this case, you can see on the left picture a little bright area, and then the middle picture you can see a little dark area, and then on the right you can see just a little change in that same area. And this means that they've had a small stroke, but not a large stroke. So that blockage of that blood vessel supplies a lot more territory than that little area that we're seeing a stroke on this study. And so, yes, we want to go ahead and try to remove that blood clot. Next, please. And again, we will try to use our advanced imaging. This is the thing that shows up on my cell phone. It says, look, this is the territory at risk. So that's that green area there. So that area has not yet died, but is at risk of dying. And so we need to get that blood clot open. Next slide, please. And so if we decide to move forward, we bring you upstairs. And this is our machine. This is our Philips biplane machine. It's a beautiful machine. I love it. It does wonderful pictures and is extremely state-of-the-art. So I'm very happy with Highlands Ranch giving us this. Basically, it is 2 X-ray machines that move. You can coordinate their movement. You can take pictures at multiple angles. If you look on the right side, you can see 2 pictures there. One is a skull with a patient looking straight out at us, and the other is a skull with the patient looking to the right. So that is an AP, meaning at the face, and then the other is going through the ear, basically a front shot and a side shot. And so that's what these biplane machines allow us to do. Next slide, please. And so we access that artery in your leg or in your arm. We take our small little tools up into the brain using X-ray. And the picture on the left is, again, another angiogram. So we take dye, we put it into the artery. It lights up the arteries that have flow going through them. And then you can see an abrupt stoppage of, again, that left middle cerebral artery that is going out to the right. The picture on the right shows what happens when we're able to remove the blood clot entirely. So you can see all those blood vessels that are now open, supplying that territory that would be responsible for moving the right side of the body, speech, memory, and movement of the eyes. And so the initial NIH of 18 afterwards is down to a 4. So that would be a great success. And typically people that have those little strokes, if we can prevent a big one, you can recover substantially with therapy and rehab. It can take some time, but nothing like having a large stroke that affects the entire one side of the brain. Next slide, please. And this is just to illustrate another case. There are multiple reasons people can have strokes. One of them is atrial fibrillation, where you develop blood clots inside your heart that then are shot up into the brain with the pumping heart. Another is atherosclerosis, or development of plaque in the arteries. This is the same reason why people have heart attacks, and you can develop these large plaques in the arteries in your neck. And so we often will treat this if you have a stroke by putting a stent in there to open it back up, or doing a surgery to actually remove that ulcerated plaque. So the picture on the left demonstrates this abrupt stoppage of the internal carotid artery. You can see that little egg-shaped area towards the bottom left. That should be a blood vessel that goes all the way up into the head. It clearly is not filling anymore. The middle picture shows that in addition to that, there is a blood clot inside of the head. And the picture on the right demonstrates removal of the blood clot in the head, and also stenting of the artery in the neck to prevent this from happening again. So we have a lot of great tools to help us with treating stroke. Next slide, please. And we grade this on how successful we are. And we just, everything in medicine, we have a grading scale. So a TICI 3 means we opened it all the way up. A TICI 0 means we were unsuccessful. Next slide, please. And so that's where the treatment out to 24 hours really developed with Dawn and Diffuse 3. Really extended our window, and that's because we've got new ways of determining if patients have areas that are at risk but not yet totally gone that we can save with these procedures. And with that, I'm going to turn it back over to Dr. Pope to talk about another study that extends the windows for the medical side of things.
All right. So I just saw one quick question. How common is an ASD or PFO as the cause of stroke? So an ASD is a atrial septal defect. That's a hole in the top part of the heart. The PFO is a kind of a version of an ASD that's related to development when you're still in utero as a fetus. The presence of PFO is very common in the general population. You know, a quarter, or even up to a third in some studies. Presence of PFO as the actual cause of a stroke, it's less common. We always look for it, but it's less common as the actual cause. And it in and of itself isn't the cause. What it does is it allows a bypass for blood clots that come from the veins in your body to skip your lungs, which is what normally would happen. And our lungs do a great job of filtering out little blood clots if they're formed. And instead of it getting filtered out in the lungs, if you have a passageway in the top part of your heart, that little clot, say you have a DVT or something like that, and a piece of it breaks loose, that little clot can skip across the top of the heart, and then it has a direct path up into the arteries, which it could make a turn north and head towards your head. So we always look for it, because if you have a large PFO or a large ASD, and the mechanism and the way the stroke looked and everything, it makes sense that was a likely culprit, then we would likely intervene and close that defect. But a large percentage of the population have small PFOs, and sometimes we're not exactly sure what to do with those. Let's see where so go one more slide, I think, and then we'll come back to the TIA versus stroke thing at the end. Don't let me forget, I saw that earlier. The last trial that we'll talk about just really briefly is the Wake Up trial that came out a couple of years ago. Essentially, this trial was another attempt to sort of extend our treatment window for the IV medication, TPA or alteplase. And what they did is similar to what Dr. Folzenlogen showed in terms of staging a stroke using MRI. Their theory was that, you know, it's a very common story. Maybe some of you know people who this has happened to, where they went to bed fine and then they woke up with stroke symptoms. And so what do we do with that? Because, you know, let's say they went to bed at 8 p.m. or 10 p.m. and now it's 7 a.m. Well, that's out of the 4.5 hour window. But what we think is that oftentimes people who are having a stroke wake up. There's something about the disruption going on with a stroke that sort of wakes them up. And so they looked at that and they said, well, if we take all the people who wake up with stroke symptoms who went to bed normal. We put them through MRI. We're able to see a stroke on one sequence, but it's not aged enough to show up on the flare, which you see down below. There's a bright spot above, and it's gone on the spot below. Does that sort of tell us that the stroke is less than 5 or 4 hours old? And so they treated people with TPA in this very specific circumstance. And if you go to the next slide, they came up with I think one more slide forward. They came up with the results that actually it does make quite a bit of difference. And the number needed to treat, while not as good as for LVO thrombectomies, is 8.7, which is still pretty strong as far as medical trials go. So if you treated 8.7 people with TPA in this circumstance, you would improve outcomes in one of those people. So it's something that is very specific, but that's kind of interesting, and it was a way for us to offer treatment to more people. So next slide, please. So to kind of wrap up that portion, the big things that we want you to take away is that time is very important. As you've seen, there's lots of options, but as time goes on, our options get more and more limited. The criteria for treatment get more and more stringent for safety reasons. And so for us to achieve the best results for our patients, we need to get them as soon as we can. And so that's really the big takeaway that I want to get across from all of that. There's some interesting things coming down the pike, both on the interventional side in stroke and otherwise, and also on the medical side with a medication called tenecteplase, which I think will probably replace TPA at some point in the next few years because it's a little safer and a little bit simpler to use. So there's always new things coming out, and so but you guys are all now pretty up to date on what we're doing these days. Next slide, please. So one thing that I'm glad Dr. Folzenlogen put in here is what's going on with stroke in the era of COVID. And what we found out, and we actually found out pretty early on in the pandemic back in the spring, is that COVID patients have strokes at a much higher rate than the general population. And there's a number of things that more than with normal infections too, higher than with influenza, the yearly flu. And there's a number of reasons for this. We see that they have this sort of systemic inflammatory response. There's probably damage to the blood vessels as part of the infection in that inflammatory state. So we're seeing these patients get, venous blood clots. They're getting arterial blood clots. We actually just had a patient, what was it, maybe like a week ago now, who was in the hospital with COVID and had a large vessel occlusion in the hospital, and so Dr. Folzenlogen had to go and fix his brain. So this is something that we're seeing quite a bit of, and so obviously if you have COVID, being even more vigilant of stroke symptoms, because it's something that we see. Particularly, we're seeing it, and actually saw it more early on, at least in my experience, was in younger folks as well. The problem, and I think what we're seeing overall with stroke, is that people are sort of scared to come to the hospital. They don't want to get exposed, understandably, they don't want to get infected. So I would say the amount of strokes that we're seeing come through are actually declining, but that's probably not because people are having fewer strokes. It's because people are afraid to seek out care. And so the message that we want to pass along is that appropriate precautions are being taken in the hospitals and the ERs. So if you have a symptom, you're worried that you might be having a stroke, don't be afraid to come to the hospital. We want to try to take care of you there. Next slide, please. And the last couple of slides here, just what are some things that you can do in your everyday life to try to lower your risk of stroke? Here's some interesting ones. So we know that getting enough fiber can help you maintain a healthy weight and reduce buildup of atherosclerosis in your blood vessels. We know that being active is helpful, again, for maintaining a healthy weight and healthy blood pressure. We know smoking is a very strong risk factor for development of all sorts of cardiovascular complications and plaque formation. Stroke definitely is on that list. We know that there are certain foods like walnuts and avocados, omega-3s, that can also reduce your risk of having a stroke help maintain healthy cholesterol levels. So those are some things that you could think about if you're not already doing, sort of incorporating into your day-to-day life. And on the next slide, I've got just a couple more tips as well. Oh, sorry. I just wanted to make sure you all remember this slide. Take a picture of it or something. Oh, no, the next one, sorry. I just threw it back in here just so we make sure we don't forget this. So this is all very important. So make a mental picture or take a phone picture of this slide so you can keep this, put it up on your refrigerator or something. All right, next slide, please. Oh, well, I had one more slide in there. Oh, you know what? I think I added it before I sent it to you guys. Really, the only other thing that it had was alcohol consumption. The most recent data on that is that moderate alcohol consumption is probably okay for a cardiovascular disease perspective. And that means limiting to 1 drink per day in women or 2 drinks per day. And if their other advice was if you're not already drinking, probably best not to start. But moderate consumption can be somewhat protective. And so the one question I know from before was a TIA versus a stroke. I know this is probably a common question, and it's complicated because it's hard from a patient perspective. It's hard from a physician perspective because they can look identical, at least in the beginning. A TIA or a transient ischemic attack, as if you aren't familiar with the acronym, is essentially a transient neurological deficit that we think comes from either a small, essentially blood clot that plugs an artery, but then resolves, whether by natural mechanism, or usually by natural mechanisms, or through some collateralization, or it's a spasm of an artery that blocks blood vessel, blocks an area of brain temporarily, and then opens back up before there's any permanent damage. The problem with the TIA is a couple of issues. One is that at the beginning, it's really impossible to distinguish the two. You won't know that it was a TIA until the symptoms resolve. By definition, the symptoms have to resolve within 24 hours, but practically speaking, most TIAs last around, a few minutes, less than 15 minutes or so in most cases. So they're not very long lasting. And oftentimes by the time the patient gets to the hospital with a TIA, the symptoms are already resolved. That's the most common thing that we see with TIAs. But from a patient perspective, you're not going to know when it's starting. So you still kind of have to follow the same advice, which is to call 911, get to the hospital. And, if your symptoms resolve, but by the time you get there, that's perfect. We still do some additional workup in those cases because we do know that people who have had a TIA, and there's as Dr. Folzenlogen mentioned, we have a score for everything. So there's a score that we can use for TIAs, helps us to stratify the risk in terms of how likely are you to have a stroke in the next 7 days and the next 90 days. And so we'll use that to sort of decide what kind of workup you might need because we know that your risk is higher. The other thing is that there's been there was a couple of trials that looked at giving a medication called Plavix, which is similar to aspirin, but a little bit more potent, in addition to aspirin in patients who have had TIA. So for 30 days, well, one study was for 3 months and one was for 21 days. I usually do a month just to make it simple, but those patients were less likely to have a stroke in those next 90 days, excuse me. So there are still things that we like to do when people have TIAs, and so we want you to come in all the same. Hope that answered your question. I know a couple people asked that. Oh, the BFAST slide. Can we put the BFAST slide back up so people can take a screenshot? And then I got a message here. Common knowledge is that blood pressure raises your risk of stroke or heart attack. Have you heard of a UK study a few years back that found patients whose pressure fluctuates from one extreme to another was in more serious risk? And what kind of treatment should an over 80-year-old male seek if he had severe fluctuations? Would stabilizers be recommended? And he has had many strokes over the past 3 years, but so far no serious brain damage. That's a complicated question. I'm not familiar with the study that you're referencing there specifically. I think that there are specific blood pressure guidelines in terms of how high we want your blood pressure to be when you're an 80-year-old versus a 70 or 60-year-old. But that doesn't really answer the question about the severe fluctuations. That can be a challenging problem because what we'll find is that people will, get really high, like in the 200s, and then you over treat that, you put them on 3-4 blood pressure medications because you see it and you're like, oh my gosh, we got to do something about this blood pressure, or they come into the hospital that way. But then they also have periods maybe when they stand up, or maybe if they've got other issues like an autonomic neuropathy or something, that they'll bottom out as well, and then they're passing out and they're dizzy all the time and all that kind of stuff. So the short answer is that big fluctuations to the high side are dangerous and can cause strokes. We definitely see that. But it's a challenge when somebody's erratic, because if we overdo it, then we cause them a whole nother host of issues. I think that there's a question about Highlands Ranch Hospital or Sky Ridge in terms of being better prepared to handle strokes. I think that both of those hospitals have similar capabilities. And I would say that, we hope that we never have to see any of you in the acute stroke setting, but we feel like at Highlands Ranch, we're going to provide the best possible care and have very few limitations as what we're able to handle. But if you live across the street from another hospital that also treats stroke, we want you to go to that hospital, because again, the time is really important. And so getting to the appropriate hospital as quickly as possible is very important. And if that happens to be Highlands Ranch Hospital, then we're happy to take care of you there. Any other questions for us or for Dr. Folzenlogen specifically? If someone has had multiple head injuries, does their risk go up? I don't, from a stroke perspective, I don't know. What do you think, Zach? I'm not sure that would increase your risk directly. I'm trying to think of a scenario where that would.
I don't have any evidence to support that would be the case. No.
Other issues, seizures and things like that we see with head injuries, but stroke not so much. Most urgent care centers are not the right place to, not just most, urgent care centers are not the right place to go if you have an acute stroke. So we get calls from urgent care centers, but those places, with very, very few exceptions, don't have the types of treatments, even the IV treatment. They definitely wouldn't have the more advanced stuff, but even the IV treatment, some small critical access hospitals, which sort of look like urgent cares, may have access to some early treatments, but almost indefinitely, those places are going to ship you to a stroke center like Highlands Ranch or otherwise. So I wouldn't go to an urgent care center, and an ambulance shouldn't take you to an urgent care center as well. So you wouldn't have to worry about it if you got into an ambulance. If parents have had strokes, are their children more likely to have strokes? Yes, in some cases. So there's certain, things that run in families from a risk perspective. So, there are genetics behind high blood pressure, there's genetics behind cholesterol. And so in that sense, diabetes even. So in that sense, if you kind of got unlucky with some of your gene pool and you've got a strong history of cardiovascular disease in your family, then you're probably at higher risk at baseline than you would have been otherwise for stroke. There's also some sort of rare genetic things that cause these odd stroke syndromes that we won't have time to get into tonight. But I think generally speaking, it's more about the stroke risk factors in terms of your cardiovascular health. And the good news about that is that with medication, blood pressure, cholesterol medication, with lifestyle, we can generally overcome a lot of that stuff. Anything else? I don't see any new ones down there.
All right, if we don't have any other questions, we can go ahead and end this. Thank you again to UCHealth for giving us the opportunity to learn about strokes. And thank you to our presenters, Dr. Brandon Pope and Dr. Zach Folzenlogen. Remember that this is a series, so make sure to sign up and join us for the next topic, which will be about fitness and dietary on January 6th at 6 p.m. You can find information regarding the other topics in this series online at hrcaonline.org/yourhealth. Thank you for coming and have a great rest of your night.
Thank you.
Thanks, everyone.
Bye.